متشكرين للحضور. هنبتدي السيشن بتاع اللان كانسر. As still most of the chairpersons not yet there, but we have to start. I'm going to start with Professor Alessandra Curioni. She's from Switzerland. Can I start now?
Let me thank the organizers.
Pleasures to be invited here to start and moderate the lung session with experts from National Cancer Institute and from all oncology centers in Egypt. First of all, it's my pleasure also co-chairs Professor Hola Khorshid, Professor Hala Aziz, Professor Ahmed, and we will tackle lung cancer session in every stage. Today, we are, all of us know lung cancer is a dismal disease. It is the most common disease after breast cancer in females and after prostate cancer in the females. And also it is the first cause of cancer all over in males and women. So to improve the outcome of this patient, those patients should be managed in a multidisciplinary approach. We have first case. It is Mrs. NNA, it is 68 years old female patient, married with no offspring, not diabetic, not hypertensive. She is a smoker, about 2 packs per day for 30 years, and stopped about 2 years ago with a strong but positive family history. This patient come to our clinic and ask some questions. First of all, doctor, I am scared of having cancer. Could I need to do any kind of screening investigations? Also, why I need and what is the benefit and what is the risk? To answer these questions, first of all, we will introduce Professor Hola Khorshid, the Chair of Medical Department Oncology at National Cancer Institute and Professor of Thoracic Malignancy. Welcome.
Well, thank you. First of all, I want to thank Dr. Rima Ahmed, Dr. Muhammad Imam, and Dr. Maha for organizing yet again a great Congress. And thank you for setting the platform of why do we need to do screening. I mean, reality is screening is an essential thing that we need to do now. So what we know that lung cancer survival has increased over the last 2 decades, awareness, the tobacco cessation, but also because of the presence of improvement in the overall survival with the early diagnosis, and that's very important, and the presence of precision diagnostics and target treatments. However, this did not reflect in our region. It did not reflect in Egypt. Why is that? First thing, the incidence is increasing, and I'll show you that in a second. And the other reason is we are having, most of our patients are diagnosed in an advanced stage disease. And we have a problem also in giving them the precision medicine because of the cost and the economical issues that we have. So what we know is that, and the numbers I can tell you now, are actually 4 and 5 times the numbers that I am putting here. These are the Globocan data that is showing that lung cancer is now the 3rd most common malignancy. It rose from being the 5th to being the 3rd most common malignancy in males, and in females also. We have an increase from 3.7 to 13.8 per 100,000. So it is increasing both in males and in females. Now, the problem with lung cancer in Egypt is that 80% of your patients with lung cancer will only come to you when they're having symptoms. And when they're having symptoms, it means that they already have an advanced disease. So, and these numbers, by the way, are going to triple in the coming years. And again, we all know that we have a problem with tobacco consumption. 50% of our males are consuming tobacco, and it's expected that this number will rise to 62 or 65% in the coming 2 years. So, as I said, and I always put this number to remind everyone, Egyptians smoke 80 billion cigarettes per year. And unfortunately, they start smoking quite young. In the low and the socioeconomical and ill-educated, they start smoking very, very young. So this is the reality of lung cancer in Egypt. The incidence is increasing. Most of the patients are diagnosed with a very late advanced disease. And we have an economical burden, and it's very difficult to give sometimes target treatments and to give the immune therapy. So difficulty in even treating the stage 4 disease. And we know that every centimeter counts. Every millimeter actually counts. So if you have a patient with 5 millimeter lung cancer, the survival will be approaching 95%. Now just add another 5 millimeters, and the survival drops to 80%. And if you have a stage 2 disease, it drops to 60%. And if you have a stage 3 disease, it drops to even 30%. And when you have a stage 4 disease, it's quite dismal. We now have better drugs that we can give, but the survival, the 5-year survival is quite dismal. And unfortunately, most of the patients will come presenting with an advanced disease. They will come presenting with symptoms, and 80% of them will not be in early disease. And the problem is that even 30% of the patients will not be amenable to get any treatment. So this is why we need to diagnose our patients with an early disease. So for any effective screening program, I need to not only detect my patients in an early disease, in a stage 1 disease, but I also need for that screening program to improve the overall survival of the patients. So what do we have? Now, we've had a lot of trials. We're having multiple trials for low-dose CT that have shown that low-dose CT does improve the survival of our patients, detects lung cancer in an early disease. We've had 2 or 3 even very big trials, the NLST and the Nelson. And however, it all started with the ILCAP in 1992. They started screening their patients, and they followed their patients, and they reported, first of all, the 10-year overall survival. So what they did is that they screened 59,000 patients, or 59,000 were screened. They were able to detect 484 cancers. 80% of those cancers were diagnosed in stage 1 disease. So can you imagine, instead of diagnosing your patient in a stage 4 disease or an advanced disease in 80% of the cases, they were able to diagnose all of the patients, almost all of the patients were diagnosed in stage 1 disease. Now, what is important is if you look at the 10-year overall survival, quite impressive. It was 92%. And last year they reported, or actually a few months ago, they reported the 20-year overall survival. So they followed their patients for 20 years. And the overall survival, and of course, they increased the number. So they were able to screen around almost 90,000 men and women. And they diagnosed 1,285. And again, 80% of those were stage 1 disease. And the overall survival was, again, at 20 years, 80%. So you do cure your patients when you diagnose them early, correct? So this was confirmed in the National Lung Screening Trial, the NLST trial. It was a very large trial, 53,000 were screened, and it was comparing CT and low-dose CT and chest X-ray, and you can clearly see that the improvement in overall survival and the decrease in the mortality, 20% decrease in the lung cancer deaths when you do low-dose CT. There was a 6.7% reduction in the overall deaths, and 70% of the patients were again diagnosed with an early stage disease. And this was again confirmed in the Nielsen trial. 15,000 patients were screened, and they were doing the screening at baseline and then every 2 years. And you can see that again, doing the low-dose CT, it really decreased the mortality from lung cancer in around, again, 25%. And why for women it was more? So when you screen women, you decrease the mortality by around 48%. You double, you improve their survival. And when they added both trials together, the mortality was decreased at 8 years to almost, they were able to save around 63% of the women and 22% of the males. And then, because it's important to discuss this trial, this is a trial from Italy, actually. And because we have a friend here from Italy, so I put the trial. So this trial, actually, this was from Milan, and what they did was they wanted to see what if we screen patients beyond 5 years? Is there any further improvement in survival? And again, in this trial, they did show that there is an improvement in survival. The 10-year decrease in risk of mortality was 39%, and 32% decrease in overall mortality with a hazard ratio of 0.6. So putting all together in a meta-analysis, there was a 4% reduction in risk of mortality for all patients. So the evidence is there. Yes, we need to do screening for all our heavy and high-risk smokers. And this, based on this, actually, the US Prevention Task Force have made the recommendation. They actually changed the recommendation that we need to screen all our patients or high-risk smokers, starting from the age of 50 to 80, current smokers who are 20 packs a year, or those who have quit smoking in the last 15 years. So this was the recommendation, and this is the current recommendation for the US task force. Now, it's important to know how to fine-tune our screening, because by the end of the day, we don't want to harm our patients by doing harm the patients by having more false positive results or exposure to radiation, or even to add financial cost. And we need that to be beneficial. As I told you, you need to diagnose your patient early, and you need to decrease the mortality, improve the survival of the patient, and decrease the hazards for that patient. So it's important to choose who are the people we're going to screen, because that's important, because now we have a campaign, and how are we going to screen them, and how often should we do that? So why false positive? Matter of fact, in all the trials that I showed you, the incidence of false positive results ranges between 1% and 30%. So imagine that you have someone and you do the low-dose CT, and then he has a lesion in the lung, and you tell him you have a lesion. So the fear, the anxiety, everything that he is there, that's a problem. So you need to, and even if you tell him 2 days later that, well, you know what, it's nothing, it is not acceptable. So it's important that we decrease the incidence of our false positive results. And how this was done by using the lung rats, it did increase the incidence of false positivity by 52%. And even the Nielsen trial, they added the size and the volume, doubling time. it also did decrease the incidence of false positive results. And definitely using AIs is important to, again, to be better able to detect your lesion with a sensitivity of more than 95%. Now, this is a recent trial. This was from the UK. They looked at all their data and they analyzed their baseline performance in the UK, and they looked at what's the incidence of false positive results. They were able to decrease and to find that it was around 2%. It will never be 0%. It will be in the ranges of 2% when you use the best imaging tools, as I told you, the BI-RAD and the AIs. So who should we screen? So the US force is mandating that it's ages between 50 to 80, 20 packs per year, and those who have been smoking in the last 15 years. Now, there are other risk modules that are there, such as the PLCO, which includes 11 other factors, and it has been shown in 2 phase 3 trials that using this risk module is actually improving on detectability of lung cancer and improving in fine-tuning the high-risk patients. And again, we know that patients who have who are of low socioeconomic status, patients who are not well educated, those are the people who are more likely to be smoking the worst type of cigarettes and getting lung cancer. So should we also screen the non-smokers? Reality is that 20% of your lung cancer patients are not smokers. The reasons can be due to secondhand smoke, exposure to radon, air pollution, and so on. However, the recommendation is that we do not screen non-smokers because they deem that the harm is more than the benefit that they see. However, there was a meta-analysis from Chinese patients around the 14, they took 14 trials that included around almost 300 141. They found that women who were non-smoking, those CT with mammography, if they had any history of prior smoking, 1 year is not, you don't need to do it every year. There was no difference between 1 year and 2 years, 2 at an early stage. So it is between, it's going to be every 2 years and depends on the risk stratification of the patient. However, if you, and you screen the patient later on, then this patient, and the patient develops a nodule, then this is most probably going to be a malignant nodule. And based on all this, we started our lung cancer screening pilot trial from the National Cancer Institute. This was in June 2022. It was named after Professor Rabab Ghaffar, who is the founder of, and we named it the Egyptian White Ribbon. And this is actually, it was, as you all know, it was done in the pyramids. And that was the first initiative ever in Egypt, Africa, and in the Middle East. It was called Breath is Life. So we decided that we wanted to do it in pilot phases. We wanted to find it. We wanted to know what are the issues that we are going to see. So it had to be a dream. We screened to the itself, and I'll tell you why we need it. So that was important from incorporated with that initiative, and we had a state-of-the-art algorithm for treatment of the lung cancer lesion. So this is where we started. It was a place that used to be slums, and the government improved it, and we chose that place because most of the people living there were smokers. They were worried about the chemicals of the leather industry. So we screened around 800 families, 1,500, and we had we did educational sessions, and we had 8 clinics per day that included pulmonologist. Clinic was used, and we had an. You can see that it was coupled also with the tobacco cessation. Ministry of Solidarity was with us in that campaign, and West Egypt. So we were worried, so we started at the age of 40 to capture all of the patients. There was a huge public awareness and TV. Can I have 3 minutes or 1 minute? I'm almost done. So we had a public awareness campaign that was everywhere in Egypt, to the extent that now we started to have people who were smokers, had no symptoms. This was a 70-year-old woman. She came to us telling us found a lung lesion. This is the power of media. People didn't know that they should be screened, so that's important. And this was, we were so happy that that was adopted by the screening initiative, the governmental screening initiative, the 100 million lives and health and presidential screening campaign. They were taking 5 malignancies. They started in June, and I know that the numbers are much higher than what I am saying. So we did have challenges, and that's important. It's adherence and retention of people, because what we saw that people were so poor. We told them that we're going to do the low-dose CT in the National Cancer Institute. They didn't have money to come. So this is something that we are putting into consideration now when we're doing the fourth wave. It's important to identify who are the high-risk people. We were able to overcome emotional barriers by using the name that we used, and it's important to ensure annual or biannual follow-up, because again, every 2 years. Now, there were a lot of logistics that I'm not going to go through with, and resources and sponsorships were important. And if you're asking, is it cost effective to go for a lung cancer screening? It is cost effective. I'll tell you why. Breast cancer screening, we've been doing it. In order to save 1 life, you need to, for lung cancer, I only need to screen 161 to save 1 life. It's all about detecting the high-risk smokers. So, and again, when I do that, I'm going to detect lung cancer in around 4%, and I'm going to detect them in early stage disease. We have all the healthcare stakeholders are there with the politicians, with the social engagement, because by the end of the day, we need to all know that this is, we are fighting against the global tobacco market that is planning to reach 262 billion in the coming 2 years. And with this, I thank you. I just wanted to pay tribute to everyone in the department, starting from Professor Abu Ghaffar and everyone who shared in this pilot trials that we did, because again, this was an NCI-initiated pilot trial. We did it, and it was sponsored by the NCI, and we dedicated our time, which is going to be on the 18th and 19th of 30th of November and 1st of December. And also, if you're interested in thoracic malignancy, where is it? Okay. Anyhow, and if you're interested in thoracic malignancy, then we have another Congress in January. So thank you very much.
Thank you, Professor Ola, for this fruitful and comprehensive lectures. So depending on this data presented by Professor Ola, we discussed a lot of all these questions with this patient, and the patients did non-contrast low-dose CT scan, and we found right upper lung lobe apical nodule about 2.7 centimeter with higher lymphadenopathy. After that, we did a mass and low mediastinal paratracheal right higher lymphadenopathy. So we discussed with these patients after that the options for further management. If there is any rule for surgery versus perioperative therapy, or if there is any rule of therapy, what is adjuvant treatment after upfront surgery. Now, Professor Hala Aziz will introduce the second speaker and to answer this question.
Ahmed Bastawisi. For the second lecture, he will role of neoadjuvant treatment in early lung cancer. Ahmed.
Thank you, Professor Hala, for your kind introduction. I would like also to thank all the organizers for kind.
So this is the outline of my presentation. I will go through a small introduction and then the different tools in the neoadjuvant setting, including chemo, chemoradiation, targeted and immunotherapy, and finally conclusions. So as just presented by Professor Ola Khorshid, the stage is definitely and logically matters. The earlier, the better. Unfortunately, we have around 50% of our patients diagnosed in earlier stage, I mean from stage 1 to 3. And this makes these patients eligible for using adjuvant or neoadjuvant treatment. So what about chemotherapy? If we look at the meta-analysis, there is some contradictory data about the value of neoadjuvant chemotherapy, but generally speaking, if we look at the overall survival gain, the absolute is in the range of around 5%, and the hazard ratio was around 0.87, corresponding to around 13% decrease in the incidence of death with the use of neoadjuvant treatment. And the question was whether is there any stratification factor to allow patients to be eligible for receiving neoadjuvant or not. And actually, all the factors, including the age, including the performance status, clinical stage, sex, and others, all fail to give a compelling evidence to use neoadjuvant chemotherapy in some categories. And so if we look at the question of whether to receive chemotherapy, either in the adjuvant or in the neoadjuvant setting versus surgery alone, so the story was definitely in favor of receiving chemotherapy either in the adjuvant or neoadjuvant setting, and the remaining question was whether to receive it in the neoadjuvant or adjuvant, and actually we didn't have a head-to-head comparison to answer this question. However, if you look at this clinical trial, which was a phase 3 non-comparative trial, forget about arm A and look at arms 2 and 3, which was chemotherapy followed by surgery, and the arm 3 was surgery followed by chemotherapy. Definitely, the aim of the trial was not to compare adjuvant versus neoadjuvant, but what I want to conclude from this clinical trial, if we look at the compliance of patients after 3 cycles, in the neoadjuvant setting, it was around 61% as compared to around 90%. In the adjuvant setting, it was 61 versus 90 in the neoadjuvant setting. What I want to say is that at least we can conclude from this clinical trial that the compliance of neoadjuvant is better than the compliance of adjuvant treatment. And what about the evidence? As we all know, the evidence for the adjuvant, if we look at the improvement in 5-year overall survival, it is in the range of 5%, which is more or less similar to the number in the neoadjuvant setting. And actually, we do not have superiority of one modality over the other. Some guidelines, for example, the ISO guidelines are more towards adjuvant setting because the evidence is more towards adjuvant. So if we look at the different comparators regarding adjuvant and the neoadjuvant, the level of evidence is more towards adjuvant. Surgical staging will be better with adjuvant. Again, earlier delivery of treatment, compliance, assessment of research criteria will be better with neoadjuvant, and availability of tissue will be much more for adjuvant treatment. So what we can tell is that we do not have evidence to support whether to give adjuvant or neoadjuvant chemotherapy, and then the story continues. What about neoadjuvant chemoradiotherapy? I invite you to look at this multi-center phase 3 clinical trial, which included patients with stage 3 ANA2 disease, randomized in a 1-to-1 fashion to receive cisplatin docetaxel plus or minus radiotherapy. So the question of the trial is whether to give concomitant chemoradiotherapy or not, and actually the trial was negative regarding both overall survival and event-free survival. So regarding chemoradiotherapy, we do not have any evidence till now to support the use of concomitant chemoradiotherapy. What about targeted therapies? As we know, in the adjuvant setting, we have the standard in EGFR mutant patients of receiving adjuvant osimertinib, but these are clinical trials assessing neoadjuvant setting. I will go back to it shortly. And some clinical trials are assessing extending of the indications of adjuvant treatment. For example, the adjuvant osimertinib is indicated for 3 years, while want to test 5 years, and it is indicated in stage 1B, defined as more than 4 centimeters and on, why not to test earlier stages like for the Abura2 and so on. But if we look at this clinical trial, which include patients with stage 3 ANA2 disease, and it was confirmed by diagnostic EGFR mutant to receive erlotinib for 42 days of chemotherapy followed by surgery, and then to receive erlotinib in the first arm, or to receive 2 more cycles of chemotherapy with a primary endpoint of overall response rate. The trial was having a response rate of 54 in the first arm versus only 34%. And there was encouraging results regarding PFS and OS. However, it was still immature. But what I invite you to look at is to look at the differential overall response rate and the pathological response rate. Look at the all clinical trials in the neoadjuvant setting, including TKI inhibitors. Look at the clinical response, it will be around 50% or more in some clinical trials. But if we look at the major pathological response defined defined as less than 10% viability in the tumor, it is lagging much more behind the clinical response. What I want to say is that we may have improvement of overall response rate, however, the pathological complete remission or even the major pathological response is lagging behind the overall response rate. And this led us to the concept of why not to add targeted therapy to chemotherapy, and this is new ATORA trial, which included 3 arms, either chemotherapy or chemotherapy plus osimertinib or osimertinib alone. And the primary endpoint is major pathological response followed by adjuvant treatment as per investigator choice, and we are waiting for the final results. So regarding the neoadjuvant targeted therapies, almost every targeted agents approved in the metastatic setting is being tested in the neoadjuvant setting, including drugs targeting ALK-ROS1 and TRAC, or even KRAS, either added to chemotherapy or added to immunotherapy. However, regarding targeted therapy, we still do not have any approved agent to be used in clinic yet. So what about immunotherapy? The use of adjuvant chemoimmunotherapy after surgery is based on the rationale of having is that we may activate the immune response post the surgery, resulting in stimulation of T cells. Hopefully, these T cells will catch for residual tumor cells and will lead to improvement of outcome. Whereas when we are using the neoadjuvant chemoimmunotherapy, the tumor is intact, and so the activation of T cell will be much more cruder, and the induction of anti-cancer immunity will be much more cruder. This is theoretically. And almost all the parameters of choosing adjuvant over neoadjuvant chemotherapy, all the historical parameters are also applied to immunotherapy. For example, the adjuvant setting, we may avoid cancellation of a potentially curative modality like surgery, whereas in the neoadjuvant setting, we have better delivery of the tumor, better compliance, intact vasculature, and so on. So this is theoretical, but what about the evidence? We have a lot of clinical trials, and the schedule of all of these clinical trials is either in the adjuvant setting, either by using surgery followed by immunotherapy after chemotherapy, like for example in the IMpower10, or after optional chemotherapy like in Chemo 091. But in the neoadjuvant setting, we have immunochemo, either followed by immunotherapy in a peri-operative setting or not, as I will discuss shortly. So regarding the evidence, we have compelling evidence that pathological complete remission correlates with clinical outcome. And if you remember in breast cancer, we had approval, for example, for pertuzumab based on improvement of pathological complete remission. So these are the neoadjuvant monotherapy trials in phase 2 clinical trial. And if you look at the major pathological response, they are ranging from 14% up to 45%. But if we look at the mature phase 3 clinical trials using the immuno-chemo combinations, the rationale in almost all of these clinical trials is either to use chemo plus immunotherapy followed by adjuvant treatment as per investigator, or to use a peri-operative approach with receiving neoadjuvant immuno in the neoadjuvant and the continuation of immuno only in the adjuvant setting. I will stop at some of these clinical trials and checkmate 816, forget about the first arm and look at nivo plus chemotherapy versus only chemotherapy in patients who are resectable 1 to 3 non-small cell lung cancer followed by surgery. The trial was actually a positive clinical trial with improvement of the primary endpoint of complete response, again, event-free survival. And this one, and the adverse events was not different from what we know about the individual adverse events of the neoadjuvant tools used. But what was recently presented a few days ago at the last ESMO is that the question of whether PD-L1 testing, the trial, by the way, was not was unselected clinical trial. And the question was, does PD-L1 expression matters? And actually, based on this presentation at the last ESMO, yes, it matters, regarding improvement of pathological complete remission and event-free and overall survival. Again, there was an update about the immunotherapy only arm or chemo-free arm of Ipi/Nivo, and the trial was positive regarding improvement of event-free and overall survival. But if we look at the initial part of the curves, there was detrimental effect initially in favor of chemotherapy as compared to immunotherapy. So be cautious, because we are talking about neoadjuvant setting, and we may lose a curative intent approach if the patient progressed. But if we look at the tail of the curve, it is in favor of the addition of the use of chemotherapy-free regimen Ipi/Nivo. Again, if we look at the pathological complete response, it was impressive. And what was more interesting is that in patients with PD-L1 negative squamous histology, there was superiority of this regimen of chemotherapy-free Nivo/Ipi, and this is a matter of further research. Another similar clinical trial was Nivo plus chemotherapy versus chemotherapy, but the difference between this clinical trial and the CheckMate 816 is that it included an adjuvant immunotherapy arm, whereas the CheckMate 816 was only neoadjuvant approach with the same population, and the event-free survival was positive. Again, the pathological complete response was positive, and the question whether to add an adjuvant arm or not, actually for this clinical trial, the adjuvant arm was improving outcome regardless of achievement of pathological complete response or not. Another clinical trial was the KEYNOTE-671, and in a similar design, but in this time we are using a pembrolizumab in an add-on fashion to chemotherapy versus chemotherapy alone, followed by an arm of pembrolizumab in patients who are stage 2 to 3A. And the trial was initially presented at the last ASCO, and it was positive clinical trial. In the last ESMO, the curves continues to separate with some statistical issues regarding censoring of overall survival. However, it is the first clinical trial to show a frank improvement of overall survival. Again, if we look at the neoadjuvant tislelizumab, again in the same fashion, I proved this slide because this is a Japanese trial which showed an impressive improvement in pathological complete response, which was unprecedented in the neoadjuvant clinical trial. And the last clinical trial derived from the ESMO I wanted to highlight is that the value of circulating tumor DNA post neoadjuvant and surgery, because we are willing to tailor treatment, whether the patient in the adjuvant setting after achievement of whatever major pathological response is candidate for adjuvant or not. One of the tools to assess this is assessment of circulating the tumor DNA. And if we look at the Asian clinical trial, there was a strong correlation between circulating the tumor DNA and the pathological complete response. Whereas the circulating tumor DNA was negative in patients who attained the complete pathological response or major pathological response after cycle 4, day 1. So in conclusion, regarding the chemotherapy, we are not in the era of chemotherapy definitely now, but chemotherapy in the neoadjuvant, we do not have evidence to support neoadjuvant versus adjuvant, but for example, ESMO is towards adjuvant because the evidence is much more. Again, neoadjuvant chemoradiotherapy is not yet recommended. Regarding neoadjuvant targeted therapies, we do not have yet any approved agent in the neoadjuvant setting. Whereas neoadjuvant immunotherapy is no longer an investigational approach, it is already a reality in non-small cell lung cancer, in resectable non-small cell lung cancer. And the debate now is not whether to go for neoadjuvant immunotherapy or not. The debate is whether to use adjuvant arm of immunotherapy post-neoadjuvant in a peri-operative approach or not. And with this, I thank you for your attention.
Thank you, Professor Ahmad, for this elegant presentation. And in MDT discussion, we discussed these opportunities with the patient to know which treatment will be candidate for this patient. And this patient started or submitted to upfront surgery and did lobectomy with mediastinal lymphadenectomy. Please. This patient submitted to right upper lobectomy and systematic mediastinal lymphadenectomy. The pathology, as we see, adenocarcinoma, grade 2, size 2.2 centimeters, but infiltrating the visceral pleura with lymphadenopathy is negative and free surgical margins. According to the staging, 7th stage, it is a T2, it is a stage 1, but in the 8th stage, T2 is stage 1B as it is infiltrating the visceral pleura. So what is, after that, the molecular profile of these patients, PD-L1 is 70% with EGFR mutant exon 19 and no other driver mutation. So the patient come to this place and what is the optimal management plan in the adjuvant? We will skip this answer to the question at the end. After 6 months, the patient come to the clinic with her sisters and also coming from the CAF. And as we see, diagnosed 2B, 78 years old women with performance status 1, squamous cell carcinoma of the lung, stage 3A, but it is unresectable. So in this case, what is the best management plan for these patients? So Professor Huda will present the third speaker in this scenario.
First, I would like to thank Dr. Ahmed for his excellent presentation, and I'm glad to present Professor Ayman Abdesami as a professor of radiation oncology, chemotherapy in the Cancer Institute and Hermel, and he's going to show us the inoperable stage 3 cancer, non-small cell cancer, state of art. Although you said that this is squamous cell carcinoma, but he's going to present non-squamous cell. Okay.
Thank you, my Professor Hoda, for this kind introduction. Now we're shifting from the early stage resectable, which is covered nicely by Professor Tawisi, to unresectable small cell, non-small cell lung cancer. This is my agenda definition, subtype outcomes, treatment in the past and present, future, and then my conclusion. It is very important to define what is the locally advanced unresectable non-small cell cancer. It is defined as stage 3 disease with sub-classification into stage 3A, stage 3B, stage 3C, in accordance with the newly proposed HTNM classification. Broadly, stage 3 non-small cell lung cancer encompasses heterogeneous combination of tumor presentation and characterized as involving low origin spread. Either increase in the tumor size, T3, T4 infiltrating extrapulmonary structure, or nodal, either N1, N2, N3. It is only not the mere nodal environment, but the number of the node involved, the size of the node involved, and the station. Is it on station or multi-station? So it is very important to define the patient with locally advanced unresectable lung cancer, and as you see in this table, it has a very poor 5-year survival. Stage A is about, if it is clinical staging, 36%, pathological 41%, and the poorest is stage 3C. Clinically, it has 5-year survival 13%, and pathologically 12%. So, it is very important in the workup for unresectable lung cancer to start by tissue biopsy, and in the past it was an open biopsy or mediastinoscopy. Now, transbronchial ultrasound needle biopsy is currently standard and avoid the more invasive technique. We can use this technique in the restaging again without the need for more invasive procedures. Another very important workup is imaging. PET-CT and MRI of the brain is of utmost importance. The value of PET-CT, it is, in addition to the staging, it helps the radiotherapist to plan his plan for the patient. In addition, metabolic tumor evaluation by PET-CT for chemoradiotherapy can be of help for radiation treatment, and also the intensity of the uptake, it has a prognostic value for the patient. So what is the treatment? Radiotherapy alone, this was an history, but still has a role nowadays, and we'll see. Combined chemoradio is the state of art until 2017, and then the state of art now is combined chemoradio with Durva as a maintenance. Radiotherapy, management of radiotherapy has undesirable effect either on the local control or the distant control. If we use only radiotherapy in a conventional manner, which is total dose of 60 gray by 2 gray fraction, it has a very poor median survival, 1 year and 5 year, 5 and 7% respectively. So is there a rule nowadays for radiotherapy? Yes, there is a rule of radiotherapy. If the patient has a performance status 3 or 4, he can withstand this intensive treatment, the combined chemoradio, and the fixation should be chosen based on the physician judgment and the patient needs. What is the rationale for combined chemoradio? We think that we saw that unresectable lung cancer have two compartments, local original compartment in the chest, distant compartment harboring potential microclasses. Thus, the paramount objective in managing this disease can be described in 2 aspects: eradicating the visible thoracic disease and diminishing the incidence of subsequent system, and hence came the rationale of combined chemoradiotherapy. This table shows the trial which showed that the chemoradio is better than the radiotherapy. The most important one of them is Dilemma, and this is the first the Dillman trial, which is in 1990. And as you see, all the trials showed that a superior 2 years and 5 year overall survival between the combined arm and the radiotherapy arm alone. Then came the question: we have 2 approaches for combined chemotherapy. We have the sequential chemotherapy, sequential chemoradio, start by chemo as an induction followed by radiotherapy, or the concurrent approach. The sequential approach has the merit of diminishing the size of the tumor, so our radiotherapist colleague can, or the radiotherapy can be more effective, because if the cross fraction is small, it is better, it is more sensitive for radiotherapy. But it has this advantage that the patient can progress during this period of induction chemotherapy. The next studies series, they look at which is the most more important or more effective. Is it the sequential or the concurrent treatment? And as you see in this table, many trials and showed that the superiority of concurrent chemoradio over sequential chemotherapy, and came the meta-analysis which was done by the non-small cell lung cancer collaborative group, who conducted a meta-analysis of 6 randomized trials containing more than 1,000 patients, and indicated a substantial enhancement in the 5-year survival, overall survival 11.3 versus 15.2, and the minimal diminution of the local recurrence. So, came the question: can improve over the standard, which is the concurrent chemoradiotherapy. Many trials tried to address this question, and despite the improvement effort to improve the still high rate of decimal failure using either induction before concurrent chemo or consolidation after concurrent chemo or new drugs or target drugs. This table shows the trials which use induction or consolidation. As you see, the cancer and leukemia group, they're using induction followed by chemo, concurrent chemo ready, and those negative trials, the p-value was 0.3. HANA trials, they used to give maintenance docetaxel, or you can say consolidation docetaxel, and there is a trial S0023, they use Giftanib Ressa as maintenance, and all the trials are negative. So still our standard is concurrent chemoradiotherapy. What about new cytotoxic drugs? The standard, as we see in our clinics and even in Europe, it was first in 1990 with the EP regimen, etoposide plus platinol. Then came the Taxol, weekly Taxol with carboplatin, and was a standard by the RTOG group trials. Is there a difference? Until now, there is no difference. So you can use any of them. Pemetrexate was addressed as a chemosensitizer, and the result was not superior, not inferior to the standard of care, but it has less toxicity, and you can use in non-squamous cell unresectable lung cancer. What about target therapy? Target therapy is not addressed widely in locally advanced lung cancer, addressed widely as adjuvant, and as Professor Bastawi said, still has no role in neoadjuvant and has no role in locally advanced unresectable lung cancer. But the presence of epidermal growth factor mutation may be associated with lower local regional recurrence and higher distant progression-free survival. Small trials using the target therapy as with concurrent radiotherapy, but there is some issues with toxicity, and the results to date do not allow recommendation outside clinical trial. Then came the breakthrough immunotherapy for locally advanced non-small cell lung cancer. And this is the rationale. There is a synergism between radiotherapy and immunotherapy. Radiotherapy induce killing of the cells, elaborate more antigens, so it make the immunity more potent and give a chance for the checkpoint inhibitor to work well. These graphs show what I just said. We have two types of immunotherapy, either checkpoint inhibitor or cancer vaccine, and which was studied extensively, which is the immune checkpoint, either PD-L1 inhibitor or PD-1 inhibitor or the CTLA4 inhibitor. This is the famous breakthrough landmark trial, the Pacific trial. Pacific trial is a large randomized trial, including more than 700 patients with stage 3 locally unresectable non-small cell lung cancer who do not progress on concurrent chemoradio, 18 years or older, WHO performance score, take care, performance score 0 or 1. If it is 2, it is not eligible for Pacific trial. Estimated life expectancy more than 12 weeks. They randomize the patient to either Durva as a maintenance, 10 milligram per kg for 12 months, or placebo. And the start of the treatment, it may be from the day 1 after concurrent chemoradio to day 42. And this timing is very important, as I will say to you. The co-primary, the endpoints with the progression-free survival and overall survival. Secondary endpoints with overall response, duration of response, and quality of life. What about the result? The study met its primary endpoint, and as you see, the median progression-free survival was 16.8 months in the Durva group compared to 5.6 months in the placebo group. What about the overall survival? The overall survival is more much in the Durva group. It reached about 28.3 versus 16.2. Update of this data was just issued in the last ASCO, and as you see, the best curve is overall survival, and the, if I can point, what I want to see, to say, where is it? Sorry for this. That's very important. What I want to see, the update trial showed maintenance of the effect of Durva versus placebo, and the overall survival increased. The 5-year overall survival increased to be about. I don't understand. The 5-year survival احنا قلنا في in the Pacific, initial Pacific, it was 26 months. In the updated 5 years, it reached to 50 something. Can you help me, please? Go to my slides. Last time. This is update. It is update, and as you see, the 16 months update, the median overall survival was 47 months versus 29 months, but the disease-free survival still at the original Pacific trial. What about the subgroup analysis? What I want to impress in this, the smoker does not benefit, unfortunately, from this regimen. Lipid status, whatever the status, both are benefit, but if it's more than 25, it's more beneficial. And EGFR, if it is positive, it is deleterious effect. What about the safety? The drug activity, other activity overall response with the duration of response is more better in Durva than the placebo. What about the safety? The regimen is tolerable, but there is more cough, more decrease in appetite, more pneumonia, but the grade 3 pneumonia is not exceeding 4.4% of the patient. So chemoradiation side effects can interfere with the effect of the immune checkpoint. This is very important. We use Durva as a immune checkpoint, check immune point, but many side effects can be present with the use of post-immune therapy and chemoradio. Most of them are the cardiac affection and the pneumonia, and this can be avoided by the newer technique of radiotherapy. The data of the Pacific was validated by the Pacific Real World. It is an ongoing retrospective trial, started from August 22 until now, and the results was in concordance with the Pacific trial. This is the guidelines, the ESMO guidelines, and I like ESMO guidelines other than NCCN guidelines because it is more for. Can I have 2 minutes, please? 2 minutes only. And I like ESMO guidelines rather than NCCN guidelines because it is more tailorable to our situation. And as you see, the unresectable chemotherapy, concurrent chemo, if no progression, Durva for 12 months. What about the ongoing trial? This is the ongoing trial, either induction therapy by Durva or Bembro or maintenance induction therapy or combination induction. You use the immuno in the concurrent radio chemo arm. Conclusion, accurate prognosis. This is very important, and the staging is very important to define the locally advanced lung cancer. Although employing radiotherapy as a sole treatment for locally advanced non-squamous cell non-small cell lung cancer is potentially curative intent. Long-term survival and local tumor control are for the most part discouraging. Thus, synergistic cytotoxic chemotherapy with radiotherapy is most prevalent treatment, and the non-less sequential radiotherapy is less than the concurrent chemo-radio associated with very severe toxicity in some patients like esophagitis and pneumonia. Currently, the standard care for patients with inoperable locally advanced lung cancer is concurrent chemo-radio followed by maintenance Durva according to the Pacific trial. Combined immune checkpoint inhibitor with radiotherapy is a sequential or concomitantly has been an area of great interest in the feasible future, and the outcome of clinical trial will continue to evolve to change our clinical practice. And lastly, I thank you very much.
Thank you, Professor Ayman, for this illustrative lectures about locally advanced non-small cell lung cancer. And coming back to our case, now we have unresectable non-small cell lung cancer female patients, and after FDT decision, recommended concurrent chemoradiotherapy as Professor Ayman discussed, and then rediscussed as a consolidation durvalumab. Also, the patient received the concurrent chemoradiotherapy, and this is the response on the right side of the image with good tolerability. But during the durvalumab administration, the patient developed dyspnea grade 1 with oxygen saturation at 90%, and bronchoalveolar lavage showed only some granulocytes, no tumor cells. So she was diagnosed as pneumonitis, and the patient started steroid discontinued durvalumab. After that, this is the resolution of the pneumonitis with good tolerability, and the patient continued treatment. Coming to another case, now after locally advanced non-small cell lung cancer, we have a patient 72 years old, female, with mild persistent cough, and CT chest showed right lobar mediastinal paramediastinal mass 2 centimeters with multiple right pulmonary nodules and left pulmonary nodules. After doing the PET CT, showed more advanced disease, and CT guided biopsy showed adenocarcinoma grade 2, immunohistochemistry confirmed lung cancer, and the molecular profile showed PD-L1 positive 70% and EGFR mutant exon ET. So the patient after that did MRI brain and showed multiple space-occupying lesions for this patient. Now we have a patient stage 4 non-small cell lung cancer, PD-L1 positive, EGFR mutant. How to proceed with these patients? So to answer these questions, we have Professor Alessandra Curioni. She was the Deputy Director of Oncology Center in Zurich University, and now she is a full Professor of Medical Oncology, especially thoracic malignancy in Freiburg in Switzerland. But it is a virtual...
Let me thank the organizers for this very kind invitation. Unfortunately, due to a conflicting meeting, I will not be able to attend, but I am with you, and it's my real pleasure to have the possibility to discuss about the many phases of EGFR mutations. My name is Alessandra Curioni, and I'm the head of oncology in Freiburg in Switzerland, and the chair at the University of Freiburg for Oncology. This is my disclosure slide. So what do we know about patients with non-small cell lung cancer? We know that there are per year roughly 30 to 35,000 new cases diagnosed. It's more common in women, and never or 4 months more occurs are the one with the most frequent diagnosis of an adenocarcinoma of the lungs with EGFR mutation. The difficulty is always to answer to patient why this kind of tumor occurred. What is the etiology? There has been a wonderful work that was presented already at ESMO last year from Charles Swanton about the fact that there are pre-existing oncogenic mutations in normal lung in non-smoking adults with EGFR mutation. And through pollution, an inflammatory reaction is started. And this leads to differentiation from a stem cell-like state of these initially mutated cells. So this means that there are two factors. One is that there is a pre-existing mutation, but on the other side is that pollution can induce EGFR mutated lung cancer. And this has been wonderfully described in a very important work that was presented as well last year. But what do we know about these EGFR mutations? Well, most important point is that there are different ones, and they are differently occurring in Asian population and Western population. What you see in this circle that was published in this publication in JCO 2022, so the other circle is the Asian population and the inner circle is the Western population. What you can see is that the most common one in exon 19 or in exon 21 mutation occur in roughly 47% of adenocarcinoma of the lungs in the Asian population and 16% in the Western. More rare ones, for example, EGFR exon 20 mutation, insertion mutations, they occur in roughly 3% of the Asian population and 1.3% in the Western. And other EGFR mutations have been described, accounting for 2.2% in the Asian and 1.6% in the Western population. So where do they occur? If we think about the EGFR, is a tyrosine kinase. In the tyrosine kinase domain is where the majority of mutations occur, either in exon 19, exon 21, and further on in exon 20 and exon 18, with more rare mutations. Now, they are different, as we can imagine, because they can be either deletion or insertion or point mutations. So these you can see with the two different color codes. But what is the most important point is that having different types of mutation, this leads to different confirmation at the end of the tyrosine kinase. And this is when we want to summarize the type of mutations. For example, the point mutations occurring in exon 18, these lead to alteration of the conformation of the tyrosine kinase, the P loop and an alpha C helix that are in a compressing mode. And then there are the classical mutations that can occur in exon 19 or in exon 20, and the most frequent one you can see here in blue in exon 21. So you will see them color-coded, the classical one. And keep in mind that when we talk about classical one, it simply means that it's the classical conformation of the mutated kinase that is occurring. Now, this makes, of course, a major difference when we have to use a treatment for the different mutations. For exon 19 and exon 21, so occurring, taken into consideration then the majority of mutations occurring, these are the classical-like alterations most frequently happening, and we will talk about how to target these alterations in the first line, what are mechanisms of resistance, what do we know for second line, and what are perspectives. Let me also mention that in exon 18, there can be an insertion, very, very rare. And in this case of these very rare mutations, usually these are sensitive to the drug afatinib. But let's talk about the most common one. And this was presented, the data with the FLAURA trial, comparing osimertinib versus the standard of care EGFR TKI, which was at that time either gefitinib or erlotinib, showing a superiority in terms of progression-free survival and in terms of overall survival, so that osimertinib became the standard of care for this population of patients with stage 4 and the common EGFR mutations. At ESMO this year, just a few days ago, it has been presented the Mariposa trial, where for the same population of patients, namely mutations in exon 19 or exon 21. And these patients in the first line have been randomized to what is the standard of care in the osimertinib compared to either amivantamab plus lazertinib or lazertinib. The primary endpoint of the study was the progression-free survival per BICR and RECIST in version 1.1. What we can see is that the primary endpoint was met with an improvement of PFS. And what is, if we want to summarize, there is an improvement in terms of PFS of 7 months. So from 16.6 to 23.7 months improvement of progression-free survival with an hazard ratio of 0.7, favoring the combination of amivantamab and lazertinib. However, to date, osimertinib is still the standard of care. And what can we do after we have given osimertinib? And this is what it has been presented, published already in the New England Journal of Medicine some years ago, is that the patient who received osimertinib first, the majority of them will undergo afterwards chemotherapy and chemotherapy regimens. So which kind of chemotherapy we can use? Well, the difficulty of what to do after osimertinib is based on the fact that we might have to understand what is the mechanism of resistance occurring after osimertinib. But this is a very important piece of work that has been evaluating single cell analysis for patients whose tumor had an EGFR mutation. The patients were treated on osimertinib, had a resistance to osimertinib. And what you can see is that at the single cell level, there are co-mutations occurring. So there is probably not only one mechanism of resistance occurring, but many of them. And what are these mechanisms of resistance? Well, these can occur either at new EGFR mutations or amplifications. They can be bypass signaling, meaning by using alterations in other kinases. They can be a transformation into another subtype of tumor, so from adenocarcinoma it transforms into small cell lung cancer or squamous, but the majority of cases is still unknown. So, is it important to know how the resistance to osimertinib will occur? And the answer is yes, because this can allow us also to choose the right treatment to be given. For example, if alterations occur in, let me just go back, off target, so outside of alterations occurring in the EGFR, there have been many studies that have been presented. One of these studies was the IMpower 150 that looked at a subgroup population of patients who had EGFR on ALK alteration. And these patients, it's roughly 10% population of patients received either bevacizumab plus chemotherapy or bevacizumab plus chemotherapy plus atezolizumab. The chemotherapy was carboplatin and paclitaxel with an improvement of PFS. These results are the background for the development afterwards, as you can see now, the overall survival data, but that's the background for the ATLAS trial presented as well at ESMO this year. The ATLAS trial included patients who had an EGFR on an ALK alteration, had no prior cytotoxic chemotherapy, but they must have become resistant to one or more EGFR ALK TKI after first or second generation of EGFR and after third generation also of TKI with a T790M mutation. So this is the resistant population of patients after osimertinib. The patients were randomized to receive either pemetrexed plus carboplatin versus the combination we have seen before in the IMpower, which is carboplatin paclitaxel as a chemo, plus bevacizumab and atezolizumab. Primary endpoint of the study was investigator-assessed PFS, and as you can see here, there is a clear benefit of in terms of PFS with an improvement from 5.6 to 8.4 months of improvement in terms of PFS with the ABCP combination, so the 4 drugs. In summary, in case of patients with this resistance to osimertinib, one possibility would be to use this chemotherapy. But what else can we use? Well, there has been very interesting study that looked at combination with other TKIs, and again with a primary endpoint being the PFS. And this is, for example, the study that has presented with a combination of sintilimab plus IBI305 plus chemotherapy versus, of course, the chemotherapy alone or versus the combination with sintilimab alone. So the data presented showed an improvement in terms of PFS by using the combination of the 4 drugs in the arm A, from 4.3 to 5.5 with osimertinib plus and reaching 7.2. But what else do we know from ESMO this year? And this has been presented is the Mariposa 2, where patients were previously treated with EGFR TKI, progressed on either osimertinib as a mono or as the most recent line. And here again, a population of patients with a common alteration of EGFR exon 19 or 21 and randomized 2 to 1 to receive either chemotherapy or amivantamab chemotherapy or amivantamab, lazertinib, and chemotherapy. Keep in mind, lazertinib is EGFR TKI. So what the primary, of course, endpoint was to see the amivantamab lazertinib chemotherapy versus chemotherapy, but also if amivantamab chemotherapy versus chemotherapy leads to an improvement. And this is what we can see here. This is Mariposa 2 study. So there is a clear improvement in terms of progression-free survival, amivantamab chemo versus chemo, from 4.2 PFS to 6.3 with amivantamab chemotherapy combination and a hazard ratio of 48. But also the combination of amivantamab lazertinib chemo versus chemo leads to an improvement of PFS from 4.2 to 8.3 and a hazard ratio of 44, which clearly means that after osimertinib, for this population of patients, this combination becomes a new other possibility, a new regimen. What about bypass signaling? And let me just go back that there are several ways of bypass signaling that can occur in terms of, for example, MET amplification upon treatment with osimertinib. And this is why the study was developed. This is a phase 2 study, the INSIGHT 2, that included patients who had EGFR mutation with a MET amplification after progression on OSI. And the patient received this combination of tepotinib plus osimertinib. There was as well in the study a tepotinib mono arm. And the data that I will present to you are looking specifically at the combination of with tepotinib. Why tepotinib? Tepotinib is a MET inhibitor. And the most important thing is how do we define the MET amplification in this population of patients? And it's very interesting because this can be either defined through FISH or through next generation sequencing. So this depends. If you have a patient with osimertinib becoming resistant, you might do either an NGS or a MET FISH to look specifically at MET. The combination of the treatment, so we're looking here at the combination, led to an improvement in terms of overall response rate. If we look specifically at the FISH or at the NGS, and the response rate was 54.5% in patients with a detected MET amplification by FISH. And this is what you can see in the waterfall plot with a combination of the 2 drugs. So another combination as well was with savolitinib, with objective responses that are roughly 30%, mainly partial responses and no complete responses with the combination. So what I do is that after osimertinib resistance, let me just go one step back, is that I analyze if there is a mechanism of resistance, and if it's met, I would use the combination. If it's not met, it depends what you have available in your country. So therefore, to keep on the combination, either amivantamab chemotherapy or the ADCP combination that we have seen in the ATLAS study. Now, another phase of EGFR mutation is occurring with exon 20 mutations. These are very different, as you can see in color code, because these are leading to different conformations of the protein. Let's focus on the most frequent one, occurring at the positions 769 and 770. So this is the inactive conformation of the EGFR. And then, as you can see, this mutation leads to an alpha C helix that goes into an alpha C helix in position. So which change the signaling of the EGFR, And there are many ways to target exon 20, either with ADCs, so with antibodies that target specific EGFR. There is the possibility, because they are in development, of course, different ADCs, but also antibodies that target anti-EGFR and anti-MET as amivantamab. And this is very important because, as you will see now, there are data that have been presented at ESMO this year targeting this. But at the same time, there have been developed several TKIs which can target EGFR from the kinase and from the intracellular activation motif of the protein. And I would like just to say what is going to change our standard of care for exon 20 mutated tumors. As you might know, the standard of care for this population of patients was chemotherapy. So the study Papillon, or Papillon in French, has compared either the standard of care chemo versus amivantamab plus chemotherapy. And what you can see here is that the primary endpoint was PFS for this population of patients. That was, of course, a treatment naive. There was an improvement of PFS from 6.7 to 11.4 with a combination treatment of amivantamab and chemotherapy. And I would like just to stop looking only at clinical trials to look briefly at the clinical case. This is a 43 years old patient, never smoker, In 2019, she had diagnosis of adenocarcinoma of the lung in stage 4. The molecular analysis showed no alteration of EGFR, ALK-ROS1, BRAF, KRAS, MET, and NTRK. The patient received therefore a carboplatin, pemetrexed, pembrolizumab combination. Second line docetaxel and was in third line ovinorelbine mono. The lack of performance status, unfortunately, was 2. So the idea here is that the analysis was performed with very small panels of PCR sequencing. Therefore, I requested an NGS to look at all, to have a broader possibility to look at the molecular alteration. And what it was found is a exon 20 insertion that is now at position 763. So you might recall what we said is that the alteration can be different, and this kind of mutation that occurs is a classical-like alteration. And therefore, it's not the classical exon 20 mutations that we have seen with the amivantamab study, but this is an insertion that leads to a classical-like alteration. So we gave osimertinib, and today the patient is still in complete remission. What does it mean for you, just briefly, is that we need to really understand what is the mutation, where is it located, within the localization of the exon, which specific mutation it is, and then we can give them the right treatment to our patients. With this, I would like to thank you very much for your kind attention, and I wish you a wonderful conference.
المحاضرة الجاية أحب أقدم أستاذ دكتور محمد عبد الرحمن، زميل عزيز، كلية طب القصر العيني، جامعة القاهرة. اتكلمنا عن management of ALK positive lung cancer.
Good afternoon, everybody. Our talk today is about metastatic ALK-positive non-small cell lung cancer. Lung cancer is the most common cancer irrespective of the patient sex. It has a poor prognosis, especially stage 4, as indicated by the decimal 5-year survival of less than 1%. The cause of this, in most of cases, is metastatic disease, either at presentation or subsequent development of metastasis. ALK-positive disease represents 3 to 7 or 8% only of the adenocarcinoma of the lung. Although relatively rare disease, but with a challengeable druggable mutation. ALK mutation results from an internal inversion inside chromosome 2, resulting in fusion between the EML gene and the ALK gene, anaplastic lymphoma kinase, with subsequent superactive kinase activity in the cell. It was first discovered in anaplastic lymphoma at the year 1994. By the year 2007, it was discovered in non-small cell lung adenocarcinoma, representing 3 to 8%. It regulates many pathways inside the malignant cells, and it usually presents in young age, never or light smokers. The diagnosis of ALK positivity depends mainly on immunohistochemistry. But with the improvement of the NGS techniques, we have the NGS technique to diagnose ALK positivity with 2 advantages. First, you can search for the specific mutation G1202R, which is resistant to some TKIs. Second, it can be done on the blood to test on circulating tumor DNA, and we have at least 2 non-inferiority studies that proven that you can do safely on the serum and not inferior in treatment decision to tissue assessment. The only disadvantage is the low yield of the circulating tumor DNA compared to the tissue biopsy. But of course, sometimes don't have enough tissue biopsy, especially at recurrence. This is the landscape of trials or drugs approved since the year 2011 till now, starting with crizotinib, the first drug approved, followed by ending by lorlatinib, approved just 2 or 3 years ago. Anti-ALK drugs do not act only against ALK, it may act against other genetic mutations like ROS1, like MET and RET. They have a specific toxicities. You should be aware about these specific toxicities of the ALK TKIs, especially toxicity responsible for treatment discontinuation, namely pneumonia and respiratory stress for crizotinib, for alectinib and brigatinib. Cognitive dysfunction is very specific to lorlatinib, and very take care about perforation, GI perforation in alectinib. Also, you should take care about lipid profile, liver enzymes, kidney function, edema, weight gain, and fatigue. These are the trials, the pivotal trials responsible for approval of ALK TKIs in ALK-positive non-small cell lung cancer, starting with crizotinib, the first drug. It was approved and used in after the profile trials. The profile 1005 was phase 2 study with the last update showed a durable median of overall survival over 20 months. Followed by the profile 1007, it was a phase 3 study that compared crizotinib to standard second-line chemotherapy, pemetrexed or docetaxel, and the trial met its primary endpoint, which was progression-free survival with hazard ratio of 0.49. For the first-line therapy with crizotinib, we have the profile 1014. The study was phase 3 comparing crizotinib to standard chemotherapy doublet of platinum plus pemetrexed, and the study was positive, met its primary endpoint of improvement in progression-free survival by about 4 months absolutely and by a hazard ratio of 0.45, but this was not translated into an overall survival advantage. All subgroups gained the benefit from crizotinib therapy, but the very important disadvantage of crizotinib is its low penetration into the CSF and the low efficacy in the intracranial disease. As you see in the profile 1014, we have better extracranial progression, but the intracranial progression is higher for crizotinib compared to chemotherapy, either in patients with harboring brain metastasis at presentation or not harboring brain metastasis at presentation. In both situations, crizotinib is inferior to chemotherapy. For the second drug, alectinib, it was approved. It was approved after the ALEX and G-ALEX as first-line therapy and two phase 2 studies in the subsequent therapy. For the first-line therapy, we have the G-ALEX. It is in Japanese patients only, comparing alectinib with the standard crizotinib as first-line therapy in metastatic ALK-positive. It showed an improvement of overall response rate by about 13%. Progression-free survival was improved by a factor of 2/3. Median progression-free survival was 10 months for crizotinib and not reached for alectinib. The same study design. يوقف الوقت. ممكن نكمل من غير السلايدز. For alectinib as first line therapy مش شغال يعني جوزها 20 مرة عشان تتحرك يعني. For alectinib we have the ALEX and G-ALEX. They have nearly the same design. As I mentioned, G-ALEX in Japanese patients only. For the ALEX study, it was a phase 3 study comparing crizotinib to alectinib as first-line therapy. The study was positive and met its primary endpoint of PFS improvement by about 50%. And of note that alectinib is superior to crizotinib, especially for intracranial disease. Only 12% of patients has CNS progression in the alectinib arm compared to 45% in the crizotinib arm. This is the progression-free survival of alectinib versus crizotinib. The improvement was translated into an absolute benefit of more than 30 months at 3 years progression-free. For the CNS disease, the progression in the CNS for alectinib was 1/4 of that in the crizotinib at 1 year. And this was translated into an improvement of overall survival by a factor of 1/3. And accordingly, NSN approved alectinib as the preferred drug at that time, the year 2017. For the second line and more, we have many phase 2 studies that showed the efficacy of alectinib with durable response regarding extracranial and intracranial disease. Coming to the third drug, ceritinib. Ceritinib was approved after the ASCEND trials. We have the ASCEND-4 as first line and ASCEND-5 as second line. For the ASCEND-4, ceritinib was compared to a standard doublet of platinum pemetrexed, and the primary endpoint also was progression-free survival. The progression-free survival was improved again by nearly 50%. Hazard ratio is 0.55, with doubling of the median progression-free survival favoring ceritinib compared to crizotinib. For the ASCEND-5, which was ceritinib in the second line setting, second line and more, after failure of crizotinib or even chemotherapy, ASCEND-5 was a positive trial and the progression-free survival overall survival, or were improved by a factor of 5 times. Progression-free survival, 5 times median progression-free survival compared to crizotinib, and 5 times improvement overall response rate, but this was not translated into an overall survival advantage. For intracranial disease, also the number of patients was small. Ceritinib showed an intracranial overall response rate more than 70% compared to less than 30% for chemotherapy, and with durable median duration of response more than 16 months. So it is not reached in the chemotherapy arm. This is not due to superiority of the chemotherapy, but nearly due to a small number of patients, only 6 patients with chemotherapy in this arm. In spite of this data, this efficacy data, ceritinib is not commonly used drug. Why? For 2 reasons. First, in the Ascended trial, crizotinib was not compared to ceritinib was not compared to crizotinib. It was compared to chemotherapy, which is no more standard now. Second, for the GI toxicity, actually the company had made a lot of effort to prove the least toxic dose. It was 750 milligram with empty stomach, compared to the previous dose of 450 with food. This decreased the GI toxicity, but up till now, still GI toxicity of ceritinib is of much concern. Coming to brigatinib, brigatinib was approved after the ALTA studies. For the first line, we have the ALTA-1L, which compared the brigatinib to the standard crizotinib, and it met as a primary endpoint of progression-free survival. Most of the drugs have a hazard ratio near 0.5. For the intracranial disease, again, brigatinib is much better than crizotinib, with tripling of the 1-year intracranial PFS. The median duration of response for the intracranial disease is less than 6 months for crizotinib and not reached for brigatinib. For brigatinib as second line and more, we have phase 2 study comparing 2 doses of brigatinib, 180 milligram versus 90 milligram, and 180 milligram was proven superior to 90 milligram in overall response rate, median duration of response, median progression-free, and overall survival. Coming to our last drug, lorlatinib, it was approved after the CROWN trial as first line and as first and subsequent therapy after an expansion trial. Very complicated design of the expansion trial. The expansion trial expanded from phase 1 with 6 expansion arms. This drug actually was the first third-generation drug in the market. It has a cyclic structure in contrast to the non-cyclic structure of all first and second generation TKIs in the ALK inhibition. This structure was made specifically for 2 reasons. First, to be more penetrating with the CSF. Second, it was designed to attack the G1202R, which is a resistant mutation. This is the expansion trial, expanded from phase 1 for ROS and ALK therapy. These expansion arms are dependent on whether it is first line or second line after what? After chemotherapy, after ALK, after both. And according to this complicated design, FDA approved lorlatinib as first line therapy with non-crizotinib ALK TKI, and as subsequent therapy for advanced non-small cell lung cancer progressing on crizotinib and at least 1 other ALK TKI. Actually, the beginning of lorlatinib is the best drug in heavily treated patients with many lines. In this trial, we have some patients taking lorlatinib as 4th and 5th line even, and it showed a response. For the first line therapy, the phase 3 study is the CROWN study, which compared lorlatinib to standard crizotinib in metastatic ALK-positive disease. It met its primary endpoint, progression-free survival, with very good hazard ratio. As I mentioned, most of the drugs has hazard ratio of 0.5. The hazard ratio here is 0.28. And this was translated to about 40% absolute improvement at 1 year for the PFS. Okay. Again, for the intracranial disease, which is of very important concern for ALK-positive and for metastatic non-small cell lung cancer in general, lorlatinib has better intracranial response compared to crizotinib, either with patients has measurable disease or non-measurable disease. The median duration of response is in the range of 10 months for crizotinib in this trial and not reached for lorlatinib. Envolanib is a recently tested drug. The phase 3 study of the envolanib is just published 2 or 3 months ago. It has improvement of progression-free survival for the independent review and the investigator assessment, but up till now it is not included in the guidelines. Further improvement and ongoing work for treatment of ALK-positive disease is directed toward addition of bevacizumab, addition of immunotherapy, or even addition of chemotherapy to ALK TKIs. I know this lecture is about metastatic disease, not early disease, but of note that in the upcoming few years, we'll see patients receiving ALK inhibitor alectinib, namely as an adjuvant treatment after the approval in the ALINA study that published a few days ago in the last ESMO conference. This is how to go through a case of ALK-positive metastatic small cell lung cancer. In conclusion, ALK-positive lung cancer represents an uncommon disease, but with a challenging druggable mutation, with accumulating evidence in the last 12 years, starting from the year 2011. For the first-line therapy, the preferred treatment of ALK-positive metastatic small cell lung cancer, if discovered during before you initiate your chemotherapy, should be one of these drugs: alectinib, brigatinib, lorlatinib. Ceritinib is a less preferred drug. Crizotinib is no more standard first line, but may be used in certain circumstances. If you discover the ALK mutation after you started your chemotherapy, you can stop your chemotherapy and shift to ALK inhibitors, or you can continue chemotherapy and give ALK inhibitor as maintenance after chemotherapy. For subsequent, this is for the first line ALK positive treatment. For the subsequent therapy, treatment depend on what was the first line, what is the extent of the disease, is it cranial or extracranial, and if you have an extracranial disease, is it limited, symptomatic or asymptomatic, or it is extensive. Accordingly, the NCCN, the last version, gives this recommendation. First, you should classify your patient. Progression after alectinib, brigatinib, ceritinib, or lorlatinib, or progression after crizotinib. For progression after alectinib, brigatinib, ceritinib, or lorlatinib, and the patient is asymptomatic, you can go for local treatment for this asymptomatic disease. Continue alectinib, brigatinib, continue the same treatment, and if you have an evidence of the G1202R mutation, you should go for lorlatinib. If you have symptomatic CNS disease, you have the same options, and you should go for the details of the management of the CNS tumors in the NCCN guidelines. If you have symptomatic disease, you should classify your patient symptomatic limited or symptomatic extensive. For symptomatic limited disease, the same option of local treatment, continue the same treatment, or shift to lorlatinib if you have the resistant mutation G1202R mutation, or you can deal with the patient having extensive disease. In extensive disease, you should give lorlatinib if not previously given, or you can go for chemotherapy according to squamous or adenocarcinoma. Most of patients are adenocarcinoma. This is the first group of patients. The second group of patients that progression after crizotinib. And in the same manner, look to the patient symptomatic or not symptomatic, cranial disease or no cranial disease, extensive or not extensive. For asymptomatic patient, you can go for the same options also, local treatment, continue crizotinib, or you can shift to other drugs, alectinib, brigatinib, ceritinib, or lorlatinib. If you have asymptomatic CNS disease, the option of continue crizotinib has been deleted from the NCCN. معلش آخر سلايد. ممكن أرجعها؟ أنا معايا دقيقتين في البتاع دي. مفيش 3-4 دقايق وقفتوها. أنا دفعة المديرة. ممكن آخد نص ساعة زيادة. دكتور ريم بتشرف إنها دفعتي. هي والدكتور هالة عزيز وهالة مشيت. If you have symptomatic CNS disease, you can go for local treatment. Change it into alectinib, brigatinib, ceritinib, or lorlatinib, but you cannot continue on crizotinib because of the low activity of crizotinib intracranial. For symptomatic systemic disease with limited disease, you can go for the same treatment local. You can continue. If you have an extracranial disease with progression, you can continue on crizotinib, but not in the CNS disease, or you can change into lorlatinib if you have the resistant mutation G1202 mutation, or you can deal with the patient as extensive disease. In extensive disease, consider shifting from crizotinib to other agent, alectinib, brigatinib, ceritinib, or lorlatinib, or give systemic chemotherapy as in NCCN guidelines, platinum doublet. Finally, you should be aware about toxicity of these drugs. Please take care of cognitive dysfunction, lorlatinib, take care of pneumonia in many of these drugs, renal hepatic toxicity, lipid profile is very important, hypertension is very important, take care of perforation in alectinib, and thank you.
Thank you, Professor Mohammed Abdurrahman, for this elegant presentation. And quickly coming to our case, started as it is EGFR mutant osimertinib, and after 4 months, she developed oligoprogression at the bone metastasis. Now we will discuss the role of SBRT in lung cancer management with Professor Ahmed Amin, Professor of Radiation Oncology at National Cancer Institute.
Good evening, everybody. Good evening, Chairperson. Okay, I'm not going to take so much of your time. I know the last sessions always should be as fast as possible, so I'm just going to share some few slides with our experience with SBRT lung cancer. Okay, so in general, when we address radiotherapy while we're managing lung cancer, it's a well-known fact that whenever we're raising the radiotherapy dose, we can achieve better control. It's a fact, but the problem we're always concerned about we have to keep eye on the normal tissue constraints. So with the SBRT, when we're delivering a higher dose per fraction, we can achieve very good response, but with a very precision and very precise treatment in order to avoid any side effects. This is the difference between the SBRT and the conventional treatment. So before doing any SBRT, and why we're doing SBRT, more SBRT, because first of all, because of the early diagnosis. And because SBRT is, we're going to see that it's addressing the early lung cancer. So with early diagnosis, we can have more cases in order to apply more SBRT techniques. Improved diagnostic tools, improved systemic therapy so that we're having better survival for our patients, advanced radiotherapy machines, better experience, stronger evidence, and interesting area of research. When we're treating lung cancer, the main issue is the tumor motion. When we're having tumor like moving in some asymmetrical way, we have to address the motion. So we have to control the tumor motion in order to treat it precisely. How to control tumor motion? Either by applying abdominal compression or to use what's called the press holding technique, so that to hold the tumor in its place so that it's not movable anyway, or to use the gating technique in the middle. The gating technique means that our machine is just delivering radiation when the tumor is in range, but whenever it's out, the machine it's off, the beam is off. Or using more advanced machines like a CyberKnife, and which is tracking the treatment, tracking the tumor while it's moving. So the SBRT for the lung tumor, we are gonna like focus on the primary lung cancer. So the radiotherapy can be used as an alternative for surgery for early non-small cell lung cancer, and here we're addressing stage 1 and stage 2 lung cancer without mediastinal lymph nodes. So it's a good alternative for surgical treatment, but so far the surgery should be the primary treatment option. What evidence we have? We have strong evidence from a phase 3 randomized trial, which is comparing SBRT versus the concurrent chemoradiotherapy for early lung cancer. And as we can see, SBRT is superior when compared to concurrent chemoradiotherapy in terms of local control and free from tumor progression. Interestingly, we even have more data that when we're comparing surgical treatment with SBRT, we're starting to have some phase 1 trials publishing an interesting data that radiotherapy is comparable to the surgical treatment, but of course it's less invasive and less morbidity, and it's almost equivalent to surgical treatment. So I believe this is a very interesting area for research, so that if we can prove that SBRT it's more or less equivalent to surgery, we're going to do so much benefit to our patients by this treatment, which is much easier in practice and of course much less morbid when compared to surgical treatment. Actually, we're not going to address the lung metastasis in our session. So before considering SBRT, we have to have advanced imaging, as you mentioned. We have to understand exactly the indication of SBRT, proper timing, the proper patient selection, proper target evaluation, evaluate the organ at risk proximity, and to have available advanced machines, and to have enough experience. And of course, this should be done within clinical trials. I'm going to share just 2 or 3 of our patients. This is, for example, one of our standard lung cancer patients, which is, this is what the standard typical case for SBRT when we're having a lung tissue all over, like surrounding the tumor, far away from all the organ at risk. So in this case, we treated it with very high dose per fraction. We deliver 60 grays over just 3 fractions. And remember, of course, that quality assurance should be done periodically for such cases. We're having different schedules, all of them approved. But for the most common used schedule now is the 5 fractions. Even most of the states centers, they are using the 5 fractions protocol because it carries much lower side effects when compared to the 3 fractions protocol. This is another more challenging patient when we're having lung cancer very proximal to the heart and the pericardium. But of course, we were able to treat it with the 5 treatment sessions. And remember that precision is the key for SBRT. So whenever, before starting treatment, we have to have a cone beam CT and to make sure that we're treating the precise location or the precise tumor location. For me, in my practice, we are using the 5 fractions treatment, and it's as I mentioned, the plan is feasible and it carries much lower toxicity profile. SBRT can also be offered to as a re-irradiation for patients who received concurrent chemoradiotherapy before, like few years ago. If they're having a local recurrence, SBRT could also be offered, but with much lower dose. And of course, we have to make sure that this is the only site of local recurrence before considering SBRT for such lesions, but more or less it's safe with lower doses. We even had some more challenging cases for metastasis. This is a case with 3 lung metastases, and we were able to treat the 3 lesions, and we had very good response, but of course with the very complex treatment and using multiple arcs, and each lesion was treated in a separate plan. Regarding the toxicity profile, what we can expect from radiotherapy for peripheral lesion, we might expect rib fractions or pain, apical sites, we have to keep eye on brachial plexus, and proximal lesions, it's well known that they are having toxicity is more common when we're treating proximal lesions, but when we're sticking to the constraints, we're not expecting to have any morbidities. And this was addressed in a systemic review, which was published comparing different fractions and different tumor locations, and was sticking to the proper treatment schedule or fractions. In regards of the location, you're not expecting to have severe grade 3 or 4 toxicities. And remember that it's challenging to follow the patients up after treatment because you might still have some avid PET scan for even more 12 months after treatment. So you have to communicate with an expert thoracic radiology while treating or while following up your patients. Just to summarize, SBRT utilizes precise targeted radiation to a tumor while minimizing radiation to adjacent normal tissue. This targeting allows treatment of small or moderate-sized tumor in either a single or limited number of fractions. Application of SBRT techniques in patients with small primary non-small cell lung cancer or lung metastases have given results similar to surgical resection, although a long-term follow-up should be done. There are no results from randomized clinical trial comparing SBRT to surgical resection so far. Thank you so much.
Thanks a lot, Professor Ahmed Amin, for his dedication to the time. As we are beyond our time, we have a lot of questions for our cases, but unfortunately we couldn't discuss this now, and we will move to the second session. And thank you for all chairpersons, thank you for all the speakers, and for the audience.